It's a pleasure to be here. Thanks for the invitation to give you some thoughts about antithrombotic therapy in PCI for cardiogenic shock, and these are my conflicts of interest. And if we summarize what we know about the results of randomized controlled clinical trials in cardiogenic shock, this is the bottom line. The early revascularization of the infarct-related coronary artery with PCI improves mortality. That's it. And if we go for PCI, we have to consider we have to be successful. So if we achieve TIMI-3 flow, mortality is improved. But if we are not successful, we are not able to open up the infarct-related artery, means TIMI-0 or 1 flow, then we will have a very high mortality, which is nearly 80%. So what's the problems of antithrombotic therapy in cardiogenic shock? We have almost no randomized studies so far. We have patients who are at high risk for both ischemic and bleeding events. And what we know is that the absorption of oral agent is delayed. Therefore, intravenous agent should be preferred. And this is a nice picture, summarizes all the problems which we encounter in cardiogenic shock. So we have patient-elected factors. The GI system is not able, most of the patients are not able to swallow drugs, and if they have a delayed absorption, the liver is not functioning well. So we have an acute kidney injury in most of these shock patients, hypotension, and we have treatment-related factors. So we have a high bleeding risk because some of these patients will have had cardiac arrest with the need for cardiopulmonary resuscitation. We have platelet activation, we have altered antithrombotic drug response, and some of these patients will be treated with targeted temporal management, and this indeed will delay absorption of oral agent. So what's the ideal drug? And this is aspirin, and we have studied aspirin in the acute trial and compared it to oral aspirin 300 milligram, and what you can see there, that within 5 minutes you will have a profound inhibition of thromboxane synthesis, and this is much lower with the intravenous agents compared to the oral agents. It seems not to be a big difference, but this is a logarithmic scale, so the difference is really several hundredfold. So what's the problem with ADP receptor antagonist, which can be given orally? They will need at least 3 to 4 hours to become effective. Clearly, prasugrel is somewhat more effective than clopidogrel, but still prasugrel needs time to be really on the place to be protective for our stents. And some of these patients will receive morphine, and morphine has an influence of the effect of P2Y12 inhibitors with a higher residual platelet reactivity in patients receiving morphine compared to those not receiving morphine, and this is true both for prasugrel and ticagrelor. I have mentioned this already, that hypothermia in patients with cardiogenic shock after resuscitation will be given very often, and this means that patients with hypothermia will have a delayed onset of action of the oral agent as well. And this is related to a high number of stent thrombosis. This is a very elegant study from Slovenia, where patients after out-of-hospital cardiac arrest undergoing coronary angiography and stenting were followed up, and they had a lot of autopsy where they could prove stent thrombosis, yes or no, and if you combine everything, you end up with a stent thrombosis rate of 20%, which is much higher than what we see usually in our patients. So what do we have on the shell? We have 4 agents, clopidogrel and prasugrel, ticagrelor, and the only intravenous available agent is cangrelor, which is a direct-acting drug, has a reversible inhibition of the P2Y12 receptor, and most importantly, the metabolism is independent of any organ function. Within minutes, you will achieve a profound inhibition of platelet aggregation. And if you stop the drug within 1 hour recovery time, platelet aggregation will be restored again. What results do we have? We have the CANTIC study where patients were treated with crushed ticagrelor plus placebo versus crushed ticagrelor plus cangrelor. And as you can see here, there was a huge difference with respect to residual platelet inhibition in the patient between placebo and cangrelor. So 2 hours post-bolus, there was a significant difference in favor of cangrelor. What's the difference between cangrelor and GP2B3A inhibitors? Almost zero here in this fabulous FASTER study. Patients were treated with either prasugrel, tirofiban, or cangrelor, and as you can see here, there was no difference between cangrelor and tirofiban with the effectiveness with respect to platelet inhibition. I have already mentioned the problem of delayed absorption in patients with out-of-hospital cardiac arrest, and again from Slovenia there's a nice randomized study. And here they compared cangrelor versus control in 30 patients. And clearly, if you treat the patient with cangrelor, you can achieve a much better platelet inhibition, regardless of which methods you use to measure platelet aggregation. So, what's the difference between GP2B3A inhibitors and cangrelor with respect to bleeding complication? This is an experimental study where you can see that axipximab compared to cangrelor is associated with a much higher ratio with respect to bleeding time, with respect to bleeding risk. And these results are therefore therefore easy to understand. This is not a randomized comparison, but anyway, it's a large number of real-life PCI where cangrelor was compared to GP2B3A inhibitors, and regardless of which bleeding definition you use, you can appreciate that there were less bleeding with the use of cangrelor compared to GP2B3A inhibitors. And the same has been observed in the CHAMPION trials. Here, a matched pair analysis of over 2,000 patients, no higher risk for stent thrombosis on ischemic events, but lower gasto bleeding, lower TIMI bleedings with the use of cangrelor. We have done some matched pair analysis of patient treated with cangrelor in cardiogenic shock with the patient from the ERBP shock trial, and as you can see here, there was a lower mortality in the patient treated with cangrelor, not a randomized comparison to be fair. And the same was true if we looked for patients included in a registry, the CAN shock registry, that we here matched the patient to patient from the carpet shock trial. And again, we have seen a lower mortality, which was almost statistically significant. The randomized trial is ongoing, the DAPT-SHOCK AMI trial. It planned to enroll over 300 patients, is now extended to over 400 patients with AMI and cardiogenic shock. It will compare crushed ticagrelor versus cangrelor. Primary endpoint will be death, MI, and stroke after 30 days. Safety endpoint, BARC bleeding. It started in 2018 and the results are expected in the next year. So what are the guidelines of this position paper suggest in patients with cardiogenic shock? Aspirin preferable in the IV formulation, and then you have to administer P2Y12 inhibitors, and the guidelines prefer ticagrelor or prasugrel over clopidogrel, but in most of the cases you should start your treatment with IV cangrelor. Then the patient will go to PCI. Clearly, transradial approach should be preferred, and as anticoagulation, IV, and unfractured heparin is the way to go. So in my mind, we have to be very effective in this patient with cardiogenic shock, and this means we have to use intravenous agents such as aspirin and cangrelor. Thank you very much.